Good afternoon to all attendees. I take this opportunity to thank the organizing committee for the invitation to give this talk and congratulate the Philippine Heart Rhythm Society on holding of the first ever virtual Congress and the occasion of their 7th annual scientific session. These are my disclosures. So with a continuously aging population, and that's coupled with the vast improvement of cardiovascular diagnosis and treatment, we are definitely going to see a growing number of patients coming in with implantable devices such as pacemakers and defibrillators. And we're going to expect to see more of them in the not so distant future. Now, while the standard of care, as far as the follow-up of these patients, consists of programming and analysis of the device by an electrophysiologist, routine tests that are done and remain useful are your standard ECG and the chest X-ray. And so the ECG, which is widely available, is usually useful in evaluating normal pacemaker function in most cases, as well as some pacemaker malfunction and what we call as pseudo abnormalities. And this is among other findings related to the patient's intrinsic rhythm as well as cardiovascular disease. Chest X-ray, on the other hand, can give us information regarding the structure of the device, the pulse generator, the lead, and is basically useful in the assessment of complications. So recognition of the important pacemaker function and malfunctions using the ECG, as well as identification of the normal and abnormal pacemaker structure based on the X-ray, are basically skills that are indispensable for the electrophysiologist, essential for cardiologists, and definitely a plus factor for the general physician. But before we discuss the so-called nitty-gritty stuff of ECG and X-ray findings in pacemaker patients, it's mandatory that we go back to the basics of a pacemaker. And so the job description of the pacemaker is basically to sense, that is bradycardia. And if it's able to sense bradycardia, it will pace. And it's going to do this continuously, repeatedly, all throughout its battery lifespan. And this it does along with other functions such as store data, plus other important functions of the pacemaker. And so the pacemaker system consists of the pulse generator implanted in the pectoral area, which contains the battery. And then you have the lead, which is implanted into the cardiac chambers. There is a clearer, this one is a clearer real-time picture of the device set with the lead and the electrode at the tip connected to the pulse generator. Now, it is also vital that we familiarize with some of the key terms that relate to pacemaker function. When we talk about capture, this refers to stimulation and depolarization of the myocardium by the pacing stimulus. When we say sensing, it pertains to the ability of the pacemaker to see the electrical signal from the lead in the particular chamber. So when we say undersensing, it refers to poor or absence of sensing of the electrical signals, while oversensing means unwanted small signals not meant to be seen are sensed by the device. And so the pacemaker senses cardiac activity through the electrograms detected by the lead electrodes. And if the patient's heart rate falls below the set rate, that is, if the patient goes into bradycardia, the pacemaker sends an electrical impulse, and that's delivered as a pacing spike. This pacing spike must be followed by an ECG waveform, designating that the myocardium captured the impulse and depolarized. So an atrial lead will lead to atrial capture, as seen in a P wave, while a ventricular lead will lead to ventricular capture, which is a wide QRS complex. And so this spike may be visible, as seen in a unipolar pacing leads, easily seen on the ECG, or it may be very small and sometimes invisible, as seen in bipolar leads. Now, an RV, or a right ventricular pacing lead, implanted in the usual configuration, which is in the right ventricular apex, basically produces a wide QRS complex with a left bundle branch block morphology. That is because the lead depolarizes the right ventricle first before the left ventricle. Now, variants include a lead that is implanted nearer to the midline, as in a septal pacing or a right ventricular outflow tract septal pacing, which will basically result in a slightly narrower paced QRS. And if you take a look at this ECG, you have also a left bundle branch block configuration, but you have an inferior axis because the lead is implanted into the right ventricular outflow tract. Today, there's a lot of work being done on the so-called His bundle pacing with the lead implanted in the septum near the bundle of His, and which supposedly provides a more physiologic type of pacing. And this will lead to a narrower paced QRS as is seen here. And of course, finally, a biventricular pacemaker, which are implanted in heart failure patients with prolonged QRS, results in a narrowish paced QRS with a right bundle branch block morphology, as there is an additional lead implanted into the left ventricle. Now, knowledge of the basic pacemaker nomenclature is very vital, and let me run you briefly through this NBG code, which consists of 5 letters, and we usually use only the first 4. So the first letter pertains to the chamber being paced, followed by the chamber sensed, and the response to pacing, whether it's inhibited or triggered, and if there is rate modulation. Now, the 5th letter refers to the presence of multi-site pacing, as seen in biventricular pacing or multi-site atrial pacing. So the usual pacemakers that we see in clinical practice are your standard VVI, the single chamber ventricular pacemaker, and your DDD, the dual chamber pacemaker. So the most common single chamber VVI consists of one lead implanted into the right ventricle, and so it senses and paces only the right ventricle. And a sense activity will inhibit pacing, as it should. Therefore, looking at the ECG, there is an intrinsic activity in the first 2 beats. Then after a set interval, the pacemaker senses bradycardia and delivers a pacing potential, followed by capture. Now, the 5th beat is an intrinsic PVC, which is sensed appropriately and thus resets the interval of the pacemaker, which will deliver a pace on the next cycle. So the basic intervals are just the lower rate, or LR, below which the pacemaker will deliver a pacing potential. Now, on the right side is your DDD, your dual chamber pacemaker, with a lead implanted into the right atrium and the right ventricle. So the device paces both the atrium and the ventricle, senses both the atrium and the ventricle and the ventricular chamber. And intrinsic activity can inhibit pacing. However, an intrinsic P wave can trigger a paced QRS, depending on the set intervals program. So looking at the ECG, we see intrinsic sinus rhythm. Then after a set interval, the device delivers an atrial paced spike with a captured P wave, which conducts through the intrinsic AV node, leading to a normal QRS. Now, on the 3rd beat, the pacemaker delivers an atrial pace and ventricular paced rhythm. While on the 5th beat, you see an intrinsic P wave, after a set of interval, the device delivers a paced spike with a captured QRS. And so, not to overburden you, the important intervals in the DDD pacing are the lower rate and the AV interval. And so it's very important that we review the standard 4 patterns of DDD pacing, the so-called 4 phases of dual chamber pacing. So the first one is basically your intrinsic sinus rhythm. This is your A sense, V sense, and you have the normal P and a normal QRS complex. So the patient's heart rate is normal, and so the device will not pace. The second is the A pace V sense. So you have a paced P wave followed by intrinsic AV conduction, leading to normal QRS, so or also known as an atrial paced rhythm. And this is the pattern seen in patients with sinus node dysfunction, but with an intact AV node or normal AV node function. Now, the third is a P wave tracking, in which the patient has an intrinsic sinus node activity, hence a sensed P wave. And at a set interval, the device paces the ventricle, leading to ventricular pace. Hence, it's called an A-sense V pace. And this is the pattern seen in patients with heart block, but intact sinus node. Lastly, you can have the AV sequential pacing, or also known as the A pace V pace, with the device delivering a paced A and a paced V. And this is basically the one seen in those patients with both sinus and AV node dysfunction. So putting all these basics at the back of our mind, we venture into the application of this knowledge in the ECG interpretation of the pacemaker function. And so the golden rule is always to go through the usual ECG systematic approach in interpretation, very much similar to a non-pacemaker ECG. So you check the regularity, check the rate, and take a look at the rhythm and waveforms. Is there a normal P wave? Is it followed by a QRS complex? Now, for the pacemaker, we ask if there is a paced rhythm as seen with a paced spike or a pacing spike. Then we check if the device is indeed sensing the intrinsic rhythm and therefore sensing the bradycardia. And that is there a pacing spike after the usual set interval of 60 beats per minute? We also take a look if the pacemaker spike is followed by appropriate capture. Is there an abnormal pacemaker behavior? So you take a look at the behavior. Is this considered to be normal or abnormal? Then we also check other stuffs like any loss of sensing or any loss of capture. Or then before we conclude, we also recheck if there is any background intrinsic rhythm. And so we read the ECG from left to right, checking the regularity, the rate, and the rhythm. And in here, we see sinus beats. Then there's a pause. Then a pacing spike, followed by a QRS capture. And another spike, then QRS capture, followed by your sinus beats. Now, looking at the ECG below, we see 2 sinus beats, followed by a pause, and then basically pacing spikes, followed by a QRS capture. So basically, these are all normal pacemaker function. Now, let's go through some couple of tracings. The first tracing here, we run through the pacemaker ECG checklist. Yes, there are pacing spikes, and they are pacing at a rate of 65 beats per minute. So they are sensing a rate of less than 65. The spikes are followed by QRS capture, and this is normal pacemaker behavior. So this interpretation is ventricular paced rhythm with good sensing and capture. Now, the second tracing here, there are spikes, an atrial and ventricular paced spike with a rate of about 70. First spike is followed by a P wave, which is an atrial capture, and the second spike is followed by a paced QRS, which is ventricular capture. Hence, the reading is an atrial pace, ventricular pace rhythm with good sensing and capture. On the third tracing, you have an intrinsic P wave, okay? And then that's followed by a pacing spike, paced QRS. And that's going at the rate of about 88 beats per minute. Now, the pacing spikes follow the intrinsic P wave. So this is what you call the A-sense V-pace rhythm with good sensing and capture. And you know that this patient has a dual chamber pacemaker. Now, let's look at the full ECG tracing. So you apply the same concept. Read the ECG from left to right, top to bottom. And in here, there are regular pacing spikes, followed by captured QRS complex at a rate of about 65 beats per minute. So this is ventricular pace rhythm with the good sensing and capture. Now, the question is this normal pacemaker behavior? Yes, it seems to be normal pacemaker behavior. And so, but the second question is, do you see an intrinsic rhythm? If you look closely, there seems to be these bumps, which appear to be P waves with no intrinsic QRS. So the intrinsic rhythm is most likely sinus, and then you have some form of a complete heart block. So that's how you're going to interpret that pacemaker. Now, looking at other tracing, we see space spikes followed by captured QRS complexes regularly. However, there's a premature QRS or wide QRS complex here, which is consistent with the PVC or a premature ventricular complex. So, and it resets the cycle with a specific interval before the next paced beat. So this is ventricular paced rhythm with good sensing and capture with an isolated ventricular complex. So in here, we see pacing spikes all throughout the 12-lead ECG. Regularly at the rate of a 93, I think about 93 beats per minute, with a paced atrial and a paced atrial beat, followed by a P wave, followed by a paced ventricular beat with a captured QRS complex. So this is a dual chamber pacemaker. This one is an atrial pace, ventricular pace, or AV sequential pacing with good sensing and capture. Do we see an intrinsic rhythm? There is none, as all beats are paced, all right? Now, looking at this tracing, we see regular pacing spikes, all right, from left to right, followed by captured QRS complexes at a rate of 88 beats per minute. And if you take a look at the spikes, they all seem to follow an intrinsic P wave. And so therefore, this is a dual chamber pacemaker sensing the intrinsic P wave and at a set interval paces the ventricle. And this is interpreted as an atrial sense ventricular pace or P synchronous pacing or P wave tracking with good sense and capture. And there's an intrinsic P wave, but all QRS complexes are paced. And so therefore, most likely this patient has heart block, which was in the indication for pacing here. In here, we see pacing spikes, all right, regularly at the rate of 60 beats per minute, followed by a captured QRS complex. So this is ventricular paced rhythm with good sense and capture. And what's the background rhythm? You take a look at the background rhythm. So there is a background rhythm of atrial flutter. Let's go through some abnormal pacemaker ECG. So following the same interpretation strategy in this first tracing, we see this pacing spike, which is not followed by waveform. Then the next one is followed by a captured QRS. And that's followed by two more paced and captured beats. Then the next two pacing spikes are not followed by any QRS complex. So the pacing spikes are pacing at a rate of about 75 regularly and sensing adequately. So this period of asystole here shows that there is no capture. Hence, this is a ventricular paced rhythm with good sensing, but intermittent poor capture. And so there's a period of asystole because of the poor capture. In the second tracing, we see pacing spikes, which come regularly. And this first one is followed by a captured QRS or a ventricular capture. Then there's this long pause without any pacing spike or capture. Then the three succeeding paced beats capture the ventricle. So the pacemaker, therefore, did not sense this pause or bradycardic rhythm and did not pace. But the other paced beats have captured. So this one is ventricular paced rhythm with poor sensing, but good capture in the paced beats. And there is a long period of ventricular asystole, about 3.5 seconds, which is not sensed by the device. More ECG strips here. So the first one shows pacing spikes, followed by ventricular capture, and at a rate of 70 beats per minute. But then there is a pause here, which is not sensed by the pacemaker, and hence it does not pace. So therefore, this is a ventricular paced rhythm with poor sensing and good capture on the paced beats. And there is an intrinsic junctional beat that is seen here. On the second strip here, where the first one is a paced beat with ventricular capture, then you have a long asystolic pause here without any pacing spikes. Hence, this is not sensed by the pacemaker. And then that's followed by two successive ventricular paced beats with capture, followed by another long asystolic pause. Hence, this is a ventricular paced rhythm, but the pacemaker is not sensing this bradycardic rhythm. So there's a poor sensing, but good capture on the paced beats. And if you look more intently, you can see that there are artifacts, which could be electrical signals or noise coming from an extrinsic source, like an electrocautery or whatever electromagnetic interference is present, which are actually sensed by the pacemaker, or properly termed oversense. Hence, the device inhibits, leading to this period of asystole. Now, in here, for the first tracing, there are pacing spikes regularly with captured QRS for the first 3 beats. Then there's this pause, all right, followed by pacing spike with capture, and then a pause again, which are not sensed properly by the pacemaker. So, well, in reality, the pacemaker is actually sensing this signal here, which is the T wave, and as an intrinsic activity, and this resets the lower rate cycle, hence this unusual pause. So this is ventricular paced rhythm with poor sensing or oversensing, but good capture on the paced beats. Now, looking at the second strip here, we see a ventricular paced beat followed by capture. Then the next paced beat or spike, next paced spike is not followed by capture. Then there's this long asystolic pause with no pacemaker spike. So you now know that there's some problem in the capture and problem with the sensing. And then the last two spikes are followed by capture. So this one is ventricular paced rhythm with intermittent poor sensing and intermittent poor capture. Take a look at this tracing. So the first two beats are ventricular paced beats with good capture. Then whoops, take a look at that. That's an intrinsic beat, most likely a PVC, all right? Then whoa, there's a pace spike here, which should not be there because it's following this intrinsic beat. It should have sensed this beat and it should have reset the interval. So you now know that there's some problem with the sensing. And then there's another intrinsic ventricular beat here, then another pacing spike, which follows immediately after. So there's some form of a problem in the sensing. Now, can you comment on the capture? So there's no capture here because it falls during the refractory period. So therefore, the pacemaker is not sensing these intrinsic beats and is pacing inappropriately. So this one is ventricular pace rhythm with intermittent poor sensing with intrinsic ventricular ectopies. Now, the first tracing here in the slide shows sinus rhythm for the first 3 beats. Then you see this pacing spikes immediately after each sinus beat, and they shouldn't be there. So there's some form of problem with the sensing. They're not sensing these intrinsic sinus beats. And the first 2 beats do not capture because they are in the refractory period of the ventricle. And then the third beat captures the ventricle. Then the last 4 beats are paced ventricular beats with capture. So this one is ventricular paced rhythm with poor sensing, but good capture. The last tracing shows sinus rhythm. Okay, take a look at the sinus rhythm beats here. Then you have these pacing spikes in between. Again, it's not sensing the intrinsic rhythm. So there's poor sensing. And in some of the beats, there are also, you can also say there's poor capture because you're supposed to capture here, but it's not capturing. You're supposed to capture here, it's not capturing, it's not refractory. So, so this one is intrinsic sinus rhythm, and you have pacemaker beats with no sensing and no capture. More tracings here. So for the first strip, we see intrinsic sinus rhythm with a bundle branch block pattern. And then there are pacing spikes in between, which are inappropriate. Okay. Therefore, the device is not sensing the intrinsic rhythm and the spikes are not associated with capture. So this one is poor sensing and capture. Let's look at the second tracing. She shows an intrinsic sinus beat here. Then 2 pacing spikes followed by ventricular capture, then another sinus beat, then a pacing spike with no capture. And then we see the pacing spikes occur inappropriately. So the first beat occurs shortly after the sinus beat, hence it is not sensing properly the signal well. And so the third paced beat does not capture because it is refractory. So this one is sinus rhythm with ventricular paced beats with poor sensing and good capture. Finally, the third tracing, we see paced spikes, all right? And in between, there are intrinsic sinus rhythm with a sinus pause over here. So the paced spikes occur inappropriately and have no capture. So this one is poor sensing and capture, but you have intrinsic sinus rhythm with a sinus pause. Now, in this 12-lead ECG, we see intrinsic sinus beats, all right? Then this is a paced spike with no capture, but it falls on the refractory period of the previous sinus beat. So there's poor sensing here. And the third beat is also a paced ventricular beat, inappropriate as it occurs shortly after the sinus beat. Hence, it is not sensing this sinus beat. And subsequent is a sinus beat followed by a paced beat and so on. So there's another paced ventricular beat here, which is inappropriate as it is shortly after this sinus beat. And so this is ventricular pace rhythm with intermittent poor sensing and predominantly good capture. Other beats fall in the refractory period, hence they do not capture. Now, pseudo abnormalities or pseudo malfunctions can also be seen on the ECG. And so these are ECG findings which appear to be malfunction, but actually represent a normal pacemaker function. So as specialists, we need to be aware of these findings which are listed here. And we'll go through them briefly. So we mentioned about P-wave tracking that is seen in dual chamber pacemakers. And basically the ECG shows an ascens ventricular pace rhythm. And these ECGs can present with a fast rhythm due to intrinsic sinus tachycardia. And so one needs to recognize that a paced ventricular beats always follow an intrinsic QRS or an intrinsic P wave. So this is commonly seen in patients with complete heart block. Now, other pseudo abnormalities relate to what we call the high rate behavior of the pacemakers. All right. So mode switch is one. So in here, a patient with a dual chamber or a DDD pacemaker once in a while can go into some form of paroxysmal atrial tachycardia or atrial high rate. And that includes an atrial fibrillation or atrial tachycardia. So the initial response of the pacemaker is to track the P waves. All right. So you have a period of P wave tracking here, but based on a set mode, it detects this high atrial rate and automatically switches to VVI mode to prevent very fast paced rates. So this ECG below is an example, and here's the onset of the tachycardia, of the atrial tachycardia, and this is the P wave tracking, and then the shift to VVI mode. And of course, this can be seen on your pacemaker interrogation. This is just one mechanism, the pacemaker, to protect the patient against very fast atrial rates. Another high rate behavior is what we call the pacemaker Wenkeback or a pseudo Wenkeback or electronic Wenkeback. So during high rates, in order to protect the patient from fast pace rhythms, the pacemaker goes into electronic Wenkeback, as you can see here. It presents with this irregular pace rhythm. So it follows the same Wenkeback pattern characterized by progressive prolongation of the PR or the P to the pace ventricular beat. Then you have a drop beat. All right, so very similar to the usual Wenkeback. So this is another form of high rate behavior. Now, another response is also what you call the 2:1 AV, the 2:1 block, as seen here. So after onset of the intrinsic tachycardia, the device automatically switches to 2:1 AV pacing mode. And this is verified in the pacemaker interrogation here and also seen here. Now, not so uncommon are your fusion and your pseudo-fusion beats, which are basically superimposition of an ineffective pacemaker stimulus on a spontaneously occurring P wave or QRS complex. So if you compare the complexes, when you say fusion beat, the morphology of the cardiac paced event is a hybrid of the intrinsic morphology and the paced beat. So it's a little narrower than the paced beat and a little wider than the intrinsic beat. But in pseudofusion, the pacemaker artifact occurs late enough that the intrinsic morphology on the ECG is not deformed, but it may appear so because of the distortion of the complex by this pacing artifact. So usually these fusion and pseudofusion beats happen when your intrinsic beat and the pacing rate are almost the same, okay? So or a bit the same, right? So in here, you take a look that the pacemaker discharges during the refractory period of the intrinsic QRS before sufficient intracardiac voltage is generated to activate the sensing circuit. So this happens when the pacing rate and the intrinsic rate is similar. So these are fusion beats. This is your complete paced beats, and that one is your pseudo-fusion beat. Okay, so that's your paced beat, and this one is your pseudo-fusion beat. So take a look here. This is a VVI pacemaker. The first three beats are intrinsic beats. Then the F points to fusion beats, and you notice that the fusion beats is a little bit narrower than the fully paced beats as seen here. And then you also have the stars here, which point to pseudo-fusion. So similar to the sinus beats, but there's just this distortion caused by the superimposition of the pacemaker stimulus on the QRS complex. Now, sometimes pacemakers are programmed with so-called hysteresis rate. No? So this feature basically allows the patient's own intrinsic rate to come in before the device delivers pacing spike. So for example, in this tracing from a patient with a VVI pacemaker that is programmed to a lower rate of 60 beats per minute, and the hysteresis rate is 40 or 45 beats per minute. The first 3 beats are intrinsic sinus beats at around 70 beats per minute. And then the patient goes into a short pause. No? But although the pacemaker is programmed to pace at the rate of 60, it allows a longer interval set as the hysteresis rate to allow the patient's own intrinsic beat to come in before it finally paces at the rate of 60. So this sort of allows the patient's intrinsic beat to come in before it paces. Right? So that's your hysteresis. So it's one way of also allowing the patient's own intrinsic rhythm to come in before you fully pace the patient. Now, rate-responsive pacemakers can also allow the device to pace faster than the default set rate. So according to the patient's metabolic parameters and the needs. So these are examples of tracings of DDDR as well as the VVIR pacing. So you can see that during rate response, the pacemaker paces at a faster rate than the baseline rate or the usual rate. Now, of course, ECG is just one window into the evaluation of the pacemaker function. So abnormalities in the form of sensing and capture malfunction warrant definitely a pacemaker interrogation from an electrophysiologist. Now, of course, chest X-ray is also the other window, and that provides information on the pacemaker structure and function. And in many times, this is requested after certain abnormalities are seen on interrogation. So in reality, full comprehensive evaluation of pacemaker function can often involve all these tests, okay, with correlation of the findings in order to come up with the correct assessment. And of course, by far, your chest X-ray remains the only imaging modality that allows routine evaluation of the physical integrity of the leads. So this imaging can actually visualize the pacemaker system and its parts, and allows assessment of the complications. Okay, it may also allow identification of the pacemaker brand or type. All right, in selected cases. But before the specifics, one must be familiar with the basic anatomic correlation of the cardiac chambers in relation to the chest X-ray. So the standard views, especially for pacemakers, are your PA view and the lateral view. And here we have the superimposed cardiac structures with the blue structures for the right ventricle and the right atrium, along with their tributaries, right? So the superior vena cava and the inferior vena cava here. And then you have the pacemaker system. The right ventricular lead is inserted into the right ventricular apex usually. And then you have the right atrial lead into the right atrial appendage, which is this area here. And then finally, the pulse generator. Now, on the lateral view, we know that the right ventricle is the most anterior chamber, and we can see the course of the right ventricular lead here, implanted into the right ventricular apex, and the right atrial lead fixed into the right atrial appendage, which is anterior. And then you have the pulse generator. So this is basically how the device would fit in. So the basic pacemaker system consists of the pulse generator. Okay, then the lead with the different parts, the fixation mechanism at the tip, the pacing and sensing electrodes, the lead body, and the connector, which attaches to the pulse generator. And these are the tips of the leads with either a passive or active fixation or screw-in fixation mechanism, then your electrodes. And so correlating with the X-ray views, we can see the images here. Okay, and sometimes you need a close-up view to get a clearer image of the lead as well as the device. Now, one of the basic principles when requesting X-ray to view the leads is that it should be a hyper-penetrated film, more like a thoracic cage X-ray. So that is in order to visualize clearly the radio-opaque lead and the pacemaker. And it should be both PA and a lateral view to allow a complete visualization of the leads. So if you just request for a standard chest X-ray, so an inadequate or under-penetrated film, might not be able to visualize the leads because it's obscured by the radio-opaque heart shadow as seen here. So in contrast, an adequately penetrated film can allow clearer assessment of the leads. So that's if you're looking for the structure of the leads or assessment of any lead structural abnormalities. Now, the pacemaker X-ray also has this simple checklist of structures which can serve as a guide for us to look for. So the device, whether it's a pacemaker or a defibrillator or something else, then you take a look at the lead, the number of leads, as well as their position, the connector pin insertion, followed by the checking the lead integrity, okay, the presence of fracture, the presence of kinks or pinch lead, and of course, complications such as lead dislodgement, perforation, or pneumothorax. So first in the checklist is to check the device, the leads and their position. So this is a chest X-ray, as you can see, of a single chamber VVI pacemaker placed via the left subclavian vein with the generator in the subcutaneous left infraclavicular fossa with an RV lead implanted to the right ventricular apical wall, as you can also see in the lateral view. This one, on the other hand, is a dual chamber DDD pacemaker with an RV lead in the right ventricular apex and the right atrial lead in the right atrial appendage, as seen on the lateral view. So this is another dual chamber pacemaker, a right ventricular lead in the apex, right atrial lead in the appendage. Now, in this variant, also a dual chamber device, but you can see that the right ventricular lead is implanted in the right ventricular outflow tract, okay, as pointed by the arrowheads here, in both the PA and the lateral view. So, okay, a lot of us are implanting more and more into the right ventricular outflow tract septum to sort of provide maybe a little bit of physiologic pacing. So as specialists, we should also be aware and cognizant of the variants as far as lead position is concerned. So the first picture here, you have a right atrial lead that is fixed to the lateral atrial wall, okay, instead of the right atrial appendage. Now this here is a right atrial lead that is fixed to the Bachmann bundle, okay? So this is a concept to provide a sort of physiologic atrial pacing and aimed at decreasing atrial fibrillation. So that one is a Bachmann bundle implanted into the superior part of the right atrial cavity. All right, now the X-ray below. So next is a right ventricular lead that is attached to the His bundle, providing the so-called His bundle pacing, which supposedly provides a more physiologic ventricular pacing. So the X-ray below is a patient with the right atrial, right ventricle, and His bundle leads, okay? And finally, this is a patient with leads in the right atrium, coronary sinus os, and the right ventricle. And the last chest X-ray here is that of a leadless pacemaker, which we're starting to see more and more lately. This bullet-shaped radio-opaque structure attached to the right ventricular wall. So there's also a central hemodialysis catheter in the right subclavian vein, and maybe that's the reason why the implanter decided to put in a leadless pacemaker. Okay, now in here is a biventricular pacemaker implanted in patients with heart failure, as well as those with intraventricular conduction delay. So this one has no atrial lead. So presumably this patient has permanent atrial fibrillation. And you see here two leads, one to the right ventricular apex, and this long one here that's coursing through the coronary sinus to the cardiac vein, as seen in the lateral view, into the anterolateral vein to pace the lateral wall of the left ventricle. Another biventricular pacemaker with the generator in the subcutaneous pocket in the infraclavicular fossa. You have the right atrial lead in the right atrial appendage, right ventricular lead in the apex, and seen on the left of the spine. And the left ventricular lead takes a course via the coronary sinus, okay, with the tip in the posterolateral epicardial vein of the left ventricular wall. So biventricular pacemaker. Now, implantable cardioverter defibrillators, or ICDs, are obvious on chest X-ray by virtue of this shock and defibrillation coil. So this thick radio-opaque structure in the RV lead distal area, as well as in the middle part, somewhere in the superior vena cava. So corresponding to the SVC coil. So that's an ICD lead. Now, on the right side, we see radiographs of single and dual chamber ICDs, right? So it's very important to recognize that the lead is that of an ICD, and you have a pulse generator which is a little bit bigger than the conventional pacemaker. Okay, so those are your ICD leads. Now, the whole CRTD combo, as shown here, with pacing leads in the right atrium, the right ventricle, and the left lateral vein. So the right ventricular lead has a defibrillation coil and an SVC coil. And so this is your left ventricular lead implanted into the left lateral vein. So this is a CRTD device. Now, one of the problems that may be encountered leading to pacing issues is the insertion or engagement of the connector pin. So this is the connector pin, right? And the connector pin of the device lead must be well seated in the so-called generator connector block. So in here, we see images of non-engaged connector pin. And take note that disconnected pin can lead to failure to pace. Okay, so these are pictures of an unengaged connector pin, and this was corrected eventually. So this will lead to pacing problems. Now, lead issues, specifically the lead integrity, is usually also commonly assessed by X-ray. So whether you're looking for fracture, kinks, or a pinch lead, that can be assessed by the X-ray. So the checklist includes looking for a fractured lead, a kink lead, or a pinch lead. And for this, it is imperative that adequate penetration of the X-ray is done in order to be able to visualize the structure of the leads. So here we see an example of a lead fracture. I hope you can see that, involving the right ventricular lead at the junction of the left first rib and the clavicle. So this is a common site of fracture leading to the so-called subclavian crush syndrome. This is an example of a narrowing of the lead and indentations due to tight sutures. So beware of those sutures, and a kink lead. All right. And finally, this is a fracture of a proximal shock coil of an ICD lead. And this can happen, right? And this is the complications that we dread. Now, this here is a complete lead fracture. You can see that there, with discontinuation of the lead wire proximal to the generator with wide gaps among the lead segments. So this represents dislodgement and migration of the lead. This one is a pinch lead, if you can see closely, and an incomplete lead fracture. So the pinching of the lead wire by the clavicle, you can see here, is quite evident. And this is a thinned out lead due to tight sutures. And finally, in here, we see a lead fracture and migration of the lead. The metal conduction fragments have actually separated. And so this can be seen on your X-ray. Now, lastly, the chest X-ray is a useful modality to assess your pacemaker complications. So when we talk about lead dislodgement, this is a not so uncommon occurrence, and we can see here dislodgement of the right ventricular lead in this single chamber device. Okay, so this can happen when you don't put enough slack, enough elbow or slack on the right ventricular lead. Now, the second one shows dislodgement of both the right atrial and the right ventricular leads by virtue of them being out of position of interest. All right, so the right atrial lead has been retracted vertically, and your right ventricular lead is already in the right atrium. In the third X-ray, the right atrial lead curls upward, as you can see, crosses itself, and with the tip positioned in the superior vena cava. Okay, so that can happen. So instead of taking a course towards the right atrial appendage, and of course, the right ventricular lead is in place in the apex. And in the lateral view here of the same X-ray, we see that the right atrial lead curls upward with a tip misplaced in the superior vena cava. Now, sometimes there can be misadventures of the lead with a malposition, such as seen here. So, which is we see an RV lead. Presumably, if you take a look at the AP view, you think that it's positioned in the right ventricle, but it turns out, if you look at the lateral view, it's in the coronary sinus and epicardial vein, as you see in the lateral view. So it's very important when you're implanting a pacemaker, always take a look at the lateral view, or if you're in the implantation table, take a look at the LAO view to make sure that you are not in the coronary sinus. So the lead is curving in a loop and then coursing anteriorly instead of descending and coursing anteriorly, as would be seen with a correctly placed right ventricular lead. Now, the third picture is a similar story, but this time with an ICD lead. So you can see those radio-opaque shock coils. And you can see that in this right-sided ICD implant, with the right ventricular lead, which has these shocking coils, presumably in the right ventricle. But when you look at the lateral lead, it turns out that it's in the coronary sinus into the left ventricular vein. Okay, so be very careful. Now, lastly, here you see this right atrial pacemaker lead, which presumably goes to the right atrial appendage on the AP view. But if you take a look at the lateral view, it turns out that this atrial lead has perforated through the atrial septum and is pointing posteriorly. So this is a perforated atrial septum lead. Okay, so a complication of pacemaker implantation. Now, a dreaded complication, of course, is your lead perforation. So this chest X-ray obviously shows the PA and a lateral view of a dual chamber pacemaker, showing where the right ventricular lead ends. So it has inadvertently perforated the right ventricular wall, okay, causing the lead tip to lie outside the cardiac chambers and within the anterior thoracic cavity. So the second chest X-ray here shows the right ventricular lead perforating through the right ventricular apex in here. And finally, the images below are a PA and lateral view of an RV lead that has perforated the right ventricular apex lying in the left hemidiaphragm. And this can cause hiccups during right ventricular pacing. And of course, finally, Twiddler syndrome is also one of those dreaded misadventures. In this syndrome, usually seen in elderly patients, those who have dementia, a patient inadvertently or deliberately rotates the device or the pacemaker generator in its pocket, so causing dislodgement of the lead. So you can see in the first X-ray, there's winding of the lead around the generator and a resultant retraction of the lead from its normal position in the heart. In the second image, a dual chamber pacemaker with a Twiddler syndrome. So chest X-ray shows the generator has been rotated by the patient, causing your lead wires to dislodge and wind around the generator. So the right atrial lead has been retracted from the right atrial appendage and lies now in the superior vena cava. And the right ventricular lead now lies in the right atrium. And finally, the third image there, you see the single chamber pacemaker with the lead wire completely reeled around the generator in here. So obviously, basically, this syndrome leads to no pacing because the leads have dislodged because of the Twiddler syndrome. Now, beware of X-ray anatomic variants. No? So this is an implant in a patient with a persistent left superior vena cava. So we can see the aberrant lead course of this left-sided implant a chest radiograph of a dual chamber pacemaker with the leads that course through a persistent left superior vena cava. Hands on the left instead of going to the right side, going to the great cardiac vein, as you see in this lateral view, out through the CS or coronary sinus os into the right atrium and the right ventricle. So it's an extra challenge to implant these leads, but you need to be aware that this is a variant that you can see on the on the chest X-ray. All right, so that's your leads implanted through a persistent left superior vena cava. Now, device variants can also be seen on the X-ray, including this subcutaneous ICD. Okay, chest X-ray, PA, and a lateral view of a subcutaneous ICD showing this pulse generator implanted close to the left mid axillary line, and the subcutaneous lead, which is containing the sensing electrodes and the shock coil placed lateral to the left mid-sternal line. Okay, now this alien-looking ECG here, ugly ECG, shows a transvenous ICD lead. Okay, obviously with the shocking coils. But you have these extra radio opaque structures here, which are subcutaneous arrays. Okay, so these are implanted, placed extra in patients who have high defibrillation threshold. So just be aware on how to recognize these subcutaneous arrays. And finally, the X-rays at the bottom are X-rays of leadless pacemakers. Okay, take note of that structure there. So you have leadless pacemakers. All right. Okay. Now, there are other possible applications of the X-ray in the identification of the pacemaker brand. Okay, so looking at the shape, the contour of the device, the alphanumeric codes, the connector birthmarks, and this had been published in journals and literature. So there are certain configuration of pacemakers that look like sunglass, a wine glass, a handbag, and so on. Okay, so this is beyond the scope of this lecture, but this might come in handy when knowledge of the brand is not known during emergency hours. And I invite you all to, especially specialists, to review some of this literature. So what does the future hold for X-ray and ECGs in the evaluation of pacemaker function? So Back to the Future is one of my favorite time travel movies. And in line with our Congress theme, I invite you to step into the DeLorean, this car time machine featured in the movie. So let's travel all the way to the future, 10 years from today, and we shall set the timeline here, the target in the dashboard, 2031. So what would the ECG and chest X-ray be like in the evaluation of pacemaker function about 10 years from now? Well, the advent of wearable technology like the Apple ECG watch can allow pacemaker patients to send ECG tracings, and the benefit of remote pacemaker monitoring, which we are already doing now, will further allow subjects to transmit device data and send back the images and analysis to the electrophysiologist who can do some remote programming while on vacation, right? Not bad. What about pacemaker radiography? So images can be sent over the cloud and through artificial intelligence may be analyzed and processed, and abnormalities like, let's say, a lead fracture diagnosed automatically, and information sent over to the doctor who's probably busy, still busy on a European trip. So obviously I'm all aching to go on that vacation. So hopefully when this pandemic ends, this will be possible. But for now, let's all continue to stay safe and healthy, and I wish you well. Thank you very much for your attention.